Hey, thank you very much. Very nice thought-provoking talks. So I will start with Dr. Schmidt. Very simple question, Dr. Baba. What you suggest to the young and enthusiastic investigator how they should start?
Um, a very important question. I think almost invariably I will say start small and learn. Don't try to do a big multi-center trial as your first research project. That would be so. You have to take small steps before you can take big ones. And I think the second piece of advice would be you wouldn't dream of going into a lab and just start mixing some reagents. You would, get a solid education in how to do proper lab research in whatever methods you will pursue. And it's actually no different in clinical research. You need to understand the methodology, and you need to at least understand statistics to the point that you can have an educated conversation with your statisticians. So basically, I have recommended to every single one of my trainees in the past, mostly neonatal fellows who expressed an interest in this line of research, to do a master's in clinical research methodology and biostatistics. And the difference really shows, and many have done that. And there are some people who are doing extremely well now in mid-career.
Yeah. The other question for you, Dr. Narwa, that the studies, there are well published or well read studies like CAP trial, and people implement it. But there are many studies who have a very good results, but the people are very afraid to implement that or to think about it twice. And then on top of that, there is a written that, the further studies needed. How you take this question when many of the studies said further studies needed?
Do you
Because
want to
this,
give me an example of a well-done study that people don't, of a treatment that people don't implement? What were you thinking of?
for example, we are just in the morning talking about the surfactant administration.
Sorry, the what?
The surfactant administration without the intubation in the morning, Dr. Peter Davis discussed about that. And in the Europe, they are like, almost like everybody is doing, especially in the Germany and the UK. But in the USA, there are very few, or the Canada, very few centers are doing this. And Peter Davis is also enthusiastic to continue that technique. But still, they are saying that there are a lot of further studies needed.
Right.
So,
Yeah, I'm glad you picked this example because I think it points out to the extra steps that need to be in place before you can translate the results of a trial into practice. And your example is perfect. And I'm actually German, so I have a little bit of a closer
yeah, I
understanding of
know.
what went on in Germany and in
Yeah.
Cologne especially. Um, uh, so a drug trial is easy to translate, like the CAP trial, right? I mean, you have a fixed drug, you have a fixed dose, you have a schedule of how you give it and the route of administration. It's easy for everyone to safely copy. This is definitely not the case with the Lisa surfactant administration. And you cannot imagine the control there is in some of these centers that have pioneered it. They won't even let every nurse come close to an extremely preterm baby. They are highly selected. There's one super trained physician and one exceptional nurse allowed to even touch these babies and come to the delivery room. And now translate that into a US context where people are learning on these babies, residents, fellows, all sorts of people, RTs, you cannot compare it. And a lot more has to be in place for the translation of that type of research. And it's not just more trials need to be done by super experienced people, but in the real world, it has to be shown to do more good than harm.
The other question for you, which is if you take a look at the NRP new guidelines and the NRP new edition we just published, if you go into the detail, most of the recommendations either they are the weak or not very strong recommendation. So how listen, and then anybody else can say that, okay, my experience is better than this recommendation. It is very weak evidence and weak recommendation. So how you deal with that sort of scenario?
Well, the delivery room NRP, of course, refers to delivery room research, and that is a very recent advent in neonatal research, right? We just need to do something. And, I saw Dr. Saugstad in the speaker's room. I think he's credited for almost single-handedly having put on the map that it is wrong to start resuscitation in every newborn baby with 100% oxygen. We just did it because nobody had studied it properly, and it is his credit really to have changed that practice for the better. But the problem with the delivery room research is that it's still pretty sketchy. It's very hard to do, which is probably why there haven't been enough studies. And here again, we have a perfect example how a new method crept in. And again, Europe seems to be always in the forefront, and that is sustained inflation. And so, it was basically already routine in some European centers. And when it was studied in a large international trial, it was stopped early by the Data Safety Committee for seemingly, and I think realistically, causing more harm than good in these, certainly not any good, and possibly some harm in these very fragile and tiny babies. So I think being guarded and careful and not jumping on the bandwagon is the right thing in many situations.
Thank you, Dr. Mohammad. For Dr. Ola Sanistar, I will catch him tomorrow. He is giving these two talks. Khassawneh, come to the ethics. Dr. Baba should talk about the ethics. You know where we are working, the ethical principles can be changed. But you didn't comment about that if the parents said that, no, I don't want this baby, and you have to remove the tube or you do what you will do in this situation, not the other way around, that the parents want to do everything. This is the different story. But we face this problem also, that the parents know the baby, parents know the thing, they are very educated parents, and they say we don't want you to do any intervention.
I think that's why this is a gray zone for everybody now. If you are practicing in a place where the American Academy of Pediatrics or Sweden Neonatal Society are declaring you the space that you can work with as a physician and give you that opportunities to work with parents, and the local law. This is why in NRP they said you should respect the local law, because in certain countries you are not allowed to follow what the parent wants in terms of withholding support or withdrawal support, and you could be in trouble as a physician. But once you have that freedom, then we have two things to consider. Number one, also the autonomy of the physician when they feel that I cannot practice in the way the parent indicate, some care that might be withholding a human being the right to live. So in this setting, I think more than one person should be involved: the obstetrician, the neonatology, sometimes the ethics committee. Some policy and guideline from every hospital should start to be formulated regarding this. For example, in UAE, I think we follow. I know many places are not following exactly the law, but the law is to probably go with resuscitation if the parent requested, once you are above 22 weeks. Now, withhold of support or requesting not to give support, we're not facing it. Like, for example, in 5-6 years in UAE, I never had a parent requesting the opposite. So we haven't been actually into that, but I'm willing to hear if anybody has a comment regarding this.
The other thing is you said about the more towards to give the right scenario, so 22 weekers to 23 weekers. So what do you think? We have to talk to the parents and then give the support, or we automatically start giving support, resuscitate these 22 plus weekers?
I said that local data and local experience and ability to save life decide the number.
I
If
think
you
you
don't
are
have
doing
any,
this.
yeah, if you don't have any survival
Yeah.
after many trials of 22 weeks, and you're seeing that you are exposing these babies to pain and suffering, prolonged dying, then there is no point. They become futile medicine, and it shouldn't be offered. But if there is a chance, one in person, two in person, I mean, it's a number. There is then futility definition will not apply, and then we start to be challenged with the dilemma of ethics and comfort, and here also some religious guilt and feeling that you are not offering the right thing to certain and injustice to this population.
Okay. Uh, Come to Jennifer. Jennifer, I will email to you because we are now in the same institute, and we really want to, because we are under Leo now. So we really want to develop this program here. So my first question is regarding the ethics. So what are the ethical responsibility of a person who is sitting far and watching everything as you showed in your video? How it is legally tackled?
Yeah, thanks for that question. So the way we work it here is that, we provide this service under either a service level agreement or a contract. And we always require that there is a physician present at the baby's bedside in person. We're not there to replace the pediatrician or family physician. So our obligations are to provide the consultation and the guidance, as you saw us do in the simulation. So we're there to assist the team, as they're working through their assessment, planning their next steps for interventions during the resuscitation, interpreting chest x-rays, blood gases, all of those things as we move through the resuscitation and stabilization of the infant. So, but it is under a service offered under a service level agreement if it's an internal site to Mayo Enterprise, or a contract if it's through with an external site.
Okay. The other thing is that what about the training of NRP or resuscitation? You can offer that?
That's also a great question. So all of the providers, and the birth hospitals need to be trained in NRP.
Yeah.
What we offer via telemedicine is when these hospitals are doing their NRP training courses, we will connect via telemedicine when they're doing their mock codes, their simulation and debriefing sessions. When they're doing one of their larger, more in-depth codes, they'll actually activate the service, and then a neonatologist will connect and we'll work with them through the simulation. So we found that to be very helpful, I think, for across multiple fronts. One, it helps, disseminate knowledge. For example, the 8th edition of NRP, either relatively minor changes with that, we can help make sure those are clear to the community hospital teams. They gain experience with interacting with us via telemedicine, making them more comfortable to activate the service clinically. And it's also nice for us because it really does help us, build and establish the relationships with these teams, as they have new physicians come on board or new nurses. It's a really nice way to interact with them and establish that kind of trustful relationship.
So I know that you are working a lot on this telemedicine and teleneonatology, and your this data is impressive. That in 2016 only 43% or 49%, and now is almost 100% getting the desired of the appropriate care. What about the other thing, other field other than neonatology? You are working on that also in the field of in the specialty of pediatrics.
Yes, outside of neonatology, we have our perinatologists, so our MFM physicians. They will do kind of the video visits to our community hospital sites to do that prenatal counseling, to provide that access again to the maternal fetal medicine expertise. So, and then if we move as babies then get older, we also have, for example, pediatric cardiology, who will do, and this is, I think, pretty common now, remote echocardiogram reads, and they also do a lot of outpatient video visits. So we're seeing a lot more digital health within, the full spectrum of care in pediatrics, whether it's, inpatient, outpatient, or, video visits to home. So I think it's pretty exciting time to see how we can extend the reach and deliver care to our patients.
So definitely I will be in touch with you. Dr. Akuma and Dr. Aiman had a very nice project. I have one or two questions regarding the size of or the proper size of the cuff you use. Did you take this into consideration? Can you unmute yourself, Akuma or Aiman?
Okay.
Yeah.
Thank you, Junaid. If you remember when I was talking about the methodology, we went in depth as to how we chose the course. They were measured before you even start, and there was a ratio that was desirable based on the manufacturer's recommendation. A circumference width ratio that was between 0.37 to 0.47. And that was what we utilized.
Aiman, in your conclusion and in your results, you didn't find any difference. So what is your preference now? Because the small babies, we automatically put the USE. So you still prefer the peripheral method or non-invasive method as compared to this?
Well,
Okay,
Mohammad, you can talk. Go ahead.
So, thank you, Akuma. So looking to the evidence, the gold standard is the invasive blood pressure measurement.
That's what I asked. Yeah.
Yeah. So this is the gold standard, and this is evidence-based. What we wanted to look at is how accurate is the oscillometric blood pressure reading, especially in extreme preterm babies. And we, according to the conclusion that we came up to, is that when it comes to mean arterial blood pressure reading, the bias is small, so we can use the oscillometric reading to measure mean blood pressure. But we should be cautious when we interpret the systolic blood pressure, because there is a tendency to overestimate the number, and also the average bias was higher. So it is a reliable, but the gold standard will remain the invasive blood pressure.
Okay.
Just to add to it, the question we wanted to answer has got clinical relevance. Clinical relevance in the sense that there are so many times you have some of these small babies whom we are monitoring their blood pressure, and you lose the invasive access and you don't have them. What then do you fall back to? Everybody will go back and measure it non-invasively. So it's a question of what we are measuring and recording meticulously day and night. Does it have any reliability or not? That was the question we wanted to look at. And if you look at those three indices we measure, systolic, diastolic, and mean, the one that was least affected was the mean by all the other variables. It is a shame that our numbers were not big, although the pair samples we measured was over 100. And we also showed a study that was published just before we started, which came to almost the same conclusions. If you read a lot of the literature, it is almost the same, that if you are going to pick any of these to rely on, then they pick the mean non-invasive if you cannot measure it invasively.
Sure. Okay, with that, thank you very much. If I have a few more questions, but because of the timing, I have to admit, I will send definitely to Dr. Jennifer and Dr. Barbara. Akuma and Khassawneh is my colleague here, so it's very easy. Just give them a call and ask them. So we will do the email. And tomorrow morning we have a session, 2 talks by Professor Ola Sekestar and also another our new colleague on non-invasive ventilation. So inshallah, whoever can join tomorrow morning, not morning, is afternoon, it's 1300 here, yours early morning. So very welcome to join. So thank you very much once again, and
Thank you.
we will see you all.
Thank you.